Minutes past noon. And we're very happy to start off this academic year with our very own Dr. Rishi Mehta, the chief of our division, to give us a talk in terms of trusting our own clinical judgment as we see patients on the inpatient side. But with that, I'm just going to hand it over to Dr. Mehta.
Yeah, we can just get going. You guys can hear me, right? Because no one said yes.
Yes.
Okay,
Yes.
great. Okay, so we're gonna go through. Uh, does this work? Okay, so point of the talk is pretty self-explanatory. I think as hospitalists, we have a lot of noise, whether it's the specialist or working with residents, following guidelines that really we don't have time to always become experts in because we have to really cover a lot of general different diseases. And so I just want to make it interactive, at least at the beginning, since we're kind of already 10 minutes over. And really just get to a point where we recognize that at the end of the day, we have to trust our clinical judgment. So the four main things going to go through is I'm going to start us off by waking us up since it's food coma time and talk about in-flight emergencies, which actually follows pretty much what we're going to be talking about because it's the ultimate follow in your clinical gut. You can't make a consult on the flight. And then we'll go through some guidelines, documentation risk. We can go through a medical legal case that I think Justin's probably an expert now because I've told him so much about it. It's my own case. And then a little bit more academic about how to handle these biases. So first and foremost, in-flight emergencies. There's only 6 here today, but that's okay. So how many have been on a flight with an emergency? 1, 2, 3, 4. Okay, great. Okay, cool. So with that in mind, Lonnie, Justin, and Eric over there, Marshall, Jean-Claude, Vicky, you guys talk about, and you can bring it up, those of you online, talk about what the case was and like how you responded and your feelings through it all and what ended up happening. Let's do that. Great.
You guys are fun. I did. Okay. You guys are fun. I did respond. I just. Oh.
Oh, yeah.
Took too much Ambien and had cirrhosis and drank too much. And then the other one, she doubled up on her blood pressure medication because we were switching time zones. We didn't know what that happened. I was gonna have, I had the guy on the flight to Germany who had COPD exacerbation from the low oxygen.
Oh, no.
And I got up because I was like, oh man, I should do it. And then I got up and there's like some other doctor that was across from me in the seat that was just like, you got this? You got this? Okay, all right. Let me know if you need anything for sure. The nurse was at mine, and the moment she heard that I was MD, they all booked it.
All
left? Yeah, they all left. And I was like a brand new attending to the case.
So those online, we heard COPD, cirrhosis, I think, syncope. But what did you guys think about like the medical legal implications of it all?
I had to leave a note. They had to write a
Yeah,
note.
okay. Jean-Claude did not do that, so we'll call his malpractice insurance
They
suit.
pulled out a note and they wanted my license. They wanted to see a copy of my license. They actually wanted me to document put my name, contact information and
Yep.
all that. So it
Was that
wasn't
domestic or international?
international.
Yeah, so Vicky's talking about international. Part of that is because international, there's laws and regulations that actually protect us, and we just have to drop the note. And then it protects us actually, though, in domestic, there's laws and regulations that protect us, but the note actually can be used later in a civil suit. So it's important to know
Like
those two things.
A civil suit against you?
Yeah, but you usually will end up being protected based on a couple laws that we're gonna talk about in a second. What are the things that you saw on the plane that you could use for, I heard syncope, COPD, so what do they have?
A dinky little stethoscope.
Nothing.
Yeah.
They don't have any-
Just with the ambient noise of the plane, can't really hear anything. Yeah.
And other people helping you, you mentioned someone who just pointed at you and said you take it.
Yeah, well, he was just like, do you think you got this? I was like,
Was he older or younger?
he was older.
Oh, okay.
Yeah.
Well, my thing is, my wife's psychiatrist, so she's a physician, but every time I say to Dr. Marshall, I'm not gonna have you.
I like my wife's rad, so she's the exact same.
And my last
Unless it's
one,
suicidal.
like a person got up and had a lot of confidence and was walking towards, and then I walked with them, and then we were doing things. And then as we were like kind of debriefing and kind of in the middle of trying to figure out some stuff, I was like, oh, so what do you practice? And she's like, oh, I'm not an MD. I'm a PhD in microbiology. Like, oh, wow. Go back into the seat right now. And I thought we were on the same page here. So, okay. Yeah. Well,
Yeah, they
they're
just
the doctor, but
Dr. Ritz.
they were pretty much using the good Sam law, I guess.
Aw.
So I was thinking about it myself. I've actually I guess I've finished residency in 2016, so it's 10 years now, and I was calculating how many flights I've been on. Obviously, we all know I can't keep up with Marshall's flight patterns or instances, but I actually calculated that on average, I have flown 7 or 8 times a year. And then if you double that up and then you do it by 10 years, it's like almost 200 flights. And I've actually had 6 emergencies on a flight. So it's the more you fly, it's just going to happen. And so it's just good to be prepared and really just follow your gut, because you're not going to have a chart. You're going to have a consultant. It's just going to be you. And you got to trust your clinical judgment. You're going to have limited information. You're not really going to use guidelines. I think the whole time you're both freaking out about legal implications, which hopefully by the end of this, you won't be as worried. And then you're really just trying to make decisions in the framework of uncertainty. The real question is just like, can you help someone fast enough in sort of a compressed version of hospital medicine or in the clinic, where literally you're given only a few facts and you got to make a decision. And ultimately, you're one piece of the puzzle. And your goal is really to make sure the captain's aware of everything that's going on so they can make the decision. Your goal is really letting the captain know the situation, whether or not they have to redirect or land, not necessarily what you can actually do in the moment, which is a little contrary to what we're used to. So in terms of the data, like everything else we do, like if I were to talk about CHF or ACS or UTI, we all know like the data, the guidelines, but in flight, we just have anecdotal stuff. So there is actual literature on it. So about 1 in 600 flights this happens. It's probably much more, it's probably higher than this. It's likely underreported. The most likely one is basically exactly what Lonnie and Jean-Claude said. So syncope, pre-syncope, and breathing issues. So if you hear a doctor on the board on board and you are someone that would want to get up and help, I think just like a code ETC is, if you're running a code ETC in your head, you're already thinking, okay, it's probably pre-syncope, it's probably maybe it's syncope, hopefully it's not seizure, hopefully it's hypertension, but you're not necessarily right away going to like Junvi handled where like someone had a knife in their body. Right? We all know what happened to Junvi. No, Jean-Claude doesn't. Yeah, so she responded to a code ETC overnight, and someone had walked into the hospital with a knife in their body and was bleeding out. So that's an extreme, right? So you don't necessarily have to prepare for that on the flight, but you should just think to yourself, okay, I'm probably going to walk into hypoglycemia, vasovagal, hypotension, some respiratory symptoms like a COPD. Obviously, if they have COPD, they're more at risk because of the cabin pressure. They're not really that dramatic of cases. The ones you guys all described weren't really that dramatic, unless you guys didn't share one of the ones that was dramatic. It's just the environment makes it feel more stressful. So just being vulnerable, but like, Lonnie, were you nervous with that experience, or yours with the ambient? Yeah, you were nervous. You were nervous, Jean-Claude.
Yeah, I was nervous because I didn't know why the guy was on the ground.
Yeah, exactly. Yeah, yours sounded more intense. But I think the nerves are pretty high. So just remember that there are some rules that protect us, and what you really have to do is essentially stabilize and get the captain to know all the information. So we're going to do 3 quick cases. Since it feels awkward to do groups, you guys can just do it all at once, since there's always 6. So this first one, these are all 3 that I dealt with, and they're very similar to what you guys already talked about. So I heard, is there a doctor on board? So I got up, went towards the back, and there was like a 20-something-year-old male that was just on the ground, grabbing his stomach on the left lower quadrant, and just saying, I'm in a lot of pain, I'm in a lot of pain. Talk about that one. Then case 2 is, I get up and I go to the front of the plane, and gentleman's pretty old, and he has oxygen already with him. He rolled it onto the plane, obviously, and he's breathing really heavily, and there's 45 minutes left, and we're over the water because we're going from Singapore to LAX. And then this last one, I hear there's a medical emergency. This happened to me last month. I hear a medical emergency on board. Oh God, we just left Copenhagen and we're going to Geneva. And I'm like, all right, here we go. And I walk up and I see an elderly gentleman, pale, diaphoretic. He's got blood around his face and all the way down his shirt, and there's clots on the ground. So talk about those 3 cases.
Oh, crap.
Yeah.
Oh.
We'll break it up. Why don't you 3 just take the first 2, and then you guys take this crazy third one. Marshall, participate, but
Oh,
Stop it down.
That's when we can.
Biggest thing, yeah, it's a poor flight,
If he's
yeah,
able to talk.
exactly, just make sure he's not, make sure he's not dying, get him to a CT scan.
It's gonna
get
be
the-
rough.
I would just be like, we talk to the ground
Yeah.
to
Did you
provide
have
away
Yeah.
and be like.
Your-
have
How
a
was the
plan
How
right
fast
now.
you can.
can wear.
You can probably
I
ask
mean, you
them.
can't really just.
You know, like,
Yeah,
the passengers, I think
They have
They
like
flew.
a leader, like,
Yeah,
you
I mean, just because
they won't open it.
they have, they have.
they have like a leader. And
Yeah,
like,
they have to put in an IV.
but
But
the bear seal, like.
I mean, I guess make sure everyone knows.
So
There's other.
the answer is.
Yeah. Yeah. Also, yeah, you already had a bunch of free envelopes, like, I can't deal with this, I'm drunk, like, I'm not doing this.
I wouldn't be surprised if
Oh, no,
there
the
were some
case
that I
two
missed.
Yeah.
You got the earplugs in, yeah,
It was-
sound isolation.
And get here, if it's going from
Yeah.
LX, you can totally step on it.
Case two,
Get
it's like,
here,
if you're
it's
45
going to
minutes on the way to LX, you're over the water,
Yeah.
it's already headed towards where you're gonna be, yeah. Turns oxygen.
Yeah.
There's a lot of it just circles.
I mean, that's for like, yeah, but I mean, you can probably
I
like
think
borrow
it
an
could be
inhaler from somebody.
unoxygenated.
I don't know.
COPD. I think you can add, but like as they go lower as an altitude, it's just better to.
Maybe we can drop 10,000 feet. Get better.
Oh, that's a long flight, man.
My wife, I know.
Okay, so I heard things like appy on the guy on the case one, but we're also about to land, something about alcohol, so maybe that, I don't know, had something to do with it, or maybe we're just talking about alcohol. And then,
No, we were joking that
Uh,
Marshall probably missed a couple emergencies because he's sleeping or he already drank. And
yeah,
I'm not-
or didn't want to get up.
Yeah.
And then I heard on the second one, we're already 45 minutes anyway.
And you're over the
oxygen, yeah. And then I didn't hear much over here on case three. Cause I couldn't
We said to land right away.
land right away.
Yeah.
Okay,
Yeah.
yeah.
On the top of the Alps, maybe.
Protect his airway. Oh my
Yes.
God.
Isn't there like you, like if that's the situation,
Yeah, we would
there,
call
you
the
call
ground
the
position.
ground control and there's a,
That's a-
you don't make a decision,
They
the
contract with them.
person on the ground makes a decision.
Yeah, so essentially, whenever you respond to an in-flight emergency, we'll go through the framework in a second, but to answer your question, yeah, usually, especially on a domestic flight, you're telling the captain and then you're communicating with a physician on the ground.
Right.
But in international waters or in international, so the Germany flight I was on, there was no one to talk to on the ground. Yeah. So, okay, but let's, just like everything else in medicine, you use your gut and then a toolkit. So the first thing you gotta do is identify yourself. You get up, you say, I'm the PhD microbiologist, I'm a physician, and you let them know what you can do. And you usually are almost always responding to a flight attendant who's already there by the patient. And then you immediately have to ask for resources. Like before you even start doing your differential, you might as well just say, can you get me the kit? And you'll be surprised how much stuff they have in the kit. Domestically, I found it a lot more lacking than internationally. Internationally, I saw nitro, normal saline, LR. They had everything. Aspirin. They didn't have pressors, but they had an EpiPen. So the international flights tend to have a little bit more. They have 14, 16 gauge IVs, which was fun to do. And then you want to stabilize and syndromize, like figure out what the syndrome is. Use ground medical support. That's what Eric and Mark were talking about. So you can say to them, look, I think this is what's going on. Can I talk to someone on the ground? So that's what I ended up doing on the first case, but the second two I couldn't. And then you make your recommendations really clear to the captain. Like, this is your time, like in residency when you're running a code, like you just fake it till you make it almost. Like you got to be confident what you're telling the captain with the information you're giving them. You can't hesitate because the captain literally has to take care of all the bodies on the plane and just needs to know your medical opinion about what's happening, not necessarily like any sort of extenuating circumstances. And then you should write a note, like Vicky said. Internationally, it's actually going to help you because they have laws to protect you. Domestically, it should also protect you because there are laws to help you in America. I just brought up the fact that there are some cases where gross negligence was claimed, and because of that, later on there was like a civil suit against a few physicians at various times over the last 10 years, but they've ended up getting out of it, but it's still a hassle. The note helped in terms of being able to say what they did. But there's this act in 2017 that basically says that we're not legally required to get up. So if they say if there's a doctor on the board and you're just like a paralegal marshal and tired or had a drink or two, if you don't want to get up because of that, you don't need to. You're legally protected. So you can't later be sued that you were on the plane and you didn't help. But we have our ethical duty to get up and try to help if we can.
Okay,
Yeah.
question. What if you're like a pathologist?
Yeah,
You know what I'm saying? Like,
Yeah.
or a psychiatrist where you're like, dude, even if I
Yeah.
did,
Yeah.
I
They
would do
try
more
to
harm
help
than
too.
good.
yeah, they should still ethically try to help and legally
Okay.
be protected. And I talked about DP, but
Yeah.
she's gone up and helped, and actually she can place an IV better than me.
Oh,
So,
damn.
but again, you're just doing the broad differential of what you think is happening. We already talked about the cases. I mean, it's basically syncope, respiratory, nausea, vomiting, or of course, someone's bleeding all over their body. But if it's simple,
No, I know, but
so
for us,
yeah,
that's
yeah.
simple, but
Yeah.
for like a radon person.
Yeah.
Right, an
Yeah.
80-year-old radiation oncologist, he's like, dude,
Right. So then in that situation, you
Yeah.
get up, you assess, you get the vitals, and you tell the captain,
so they're still.
this is
oh,
beyond my whatever,
Okay.
cardiac ground support.
Yeah.
But we're all internists, so we don't, what's up?
I've been involved in a bunch of these, but maybe you put the note.
Yeah, so they have notes that you can, for some domestic flights, it's just a blank piece of paper with lines on it. And you can write it there. And then the international flights are great. They're templated. They
Did
actually
you
say,
ask for it? Because I've never been on.
yeah, you should ask for it. They should be giving it to you, but you should ask for it. So in the first case, they didn't give it to me, so I didn't actually do it. I didn't know. Like I said, I've been involved in 5. These are just the 3 interesting ones. The second one, they gave me the note, and the third one was pretty wild. So when we landed, the captain and I were talking, and he's like, "Okay, write down everything right now." So, yeah, you definitely want to ask for that.
I had a dad.
Does that mean you bring?
Yeah.
Oh, wow.
Yeah.
A stroke, when they determined later, it was a stroke and she died. But, and it was domestically, but nobody asked for a note. They just asked my business card and that's really it.
Yeah, so it's always good to protect yourself with a note,
Yeah.
and then put your medical license and credentials and all of that. And that's part of the guidelines in the Aviation Medical Assistance Act. And then the Good Sam law, which is, okay, so the first one says you don't have to get up, but yeah, I think you should. The second one is, okay, now what if I get up and I do something, am I gonna get in trouble for it? And again, I can't say 100% certainty that you won't get pulled into a dispute in America, because America is pretty litigious, but internationally for sure. And in America, this law should protect you, that the captain is taking the responsibility, which is why you got to give the captain the most amount of information. So they actually have the most liability.
Does this apply to both domestic and international, or is this also?
So these laws are domestic.
Oh, these are
And international, I should be clear, I'm talking about, so the EU has a lot more laws protecting physicians, and then international waters. I don't know anything about Asia, and I didn't look at the Asia for this. But yeah, so any questions about that? That's a good question or document.
So I heard something about the Good Samaritan law. I don't know if you'll cover it, but that you shouldn't, if like the airline afterwards offers you
Yeah,
some sort of.
yeah.
Okay,
Once
let's talk
you
about that.
take something, you no longer apply for the Good Sam law. And now if something does go wrong, you weren't acting out of a physician who has expertise and just wants to help. You're now acting as someone who took something from that. So
What's considered?
the first flight I was on, JetBlue just gave me money in my account and I didn't know. So I was like, oh gosh, but the first case wasn't complicated, so whatever. The second one, I got 2 bottles of wine and I was like, this is pretty cool. And then later I looked up, I was like, I should have taken it. And the third one, they were gonna do a lot of stuff because of what happened. And I was like, I don't want anything. I don't wanna know anything. They were going to comp me. It doesn't matter. I'll talk after.
Okay.
We gotta keep going. But it was gonna be a lot. And I was like, no, I don't want anything. Okay.
I shouldn't take my upgrade.
So yeah, I mean, it just means then what John said, you just
So anything can constitute as payment?
yeah,
So
it's
like
not
they
amount.
give you-
Like
they give you a
anything.
toothbrush.
Anything.
They gave me like a gift
Yeah,
set.
because you're doing it, because the Good Sam law is protecting you, that you're doing it out of your goodness of your. So case 1 was pretty straightforward. I went there, of course, I was thinking Appy, but it was left lower. He's also young. So it was like 7 a.m. He was probably drinking the night before. I don't know why he was reaching his left lower, but again, we're internists, so by the time we see patients, the ED is stabilized, and so sometimes they don't always present the way they do in your textbook. But literally, I was just talking to him. We had no heart history, no smoking history. I mean, your mind's going through like AAA and like Coley and all this stuff, and none of it made sense. And I just opened up a thing and gave him a Pepsid and a PPI, and then the captain asked if he did the land emergency. I'm like, we're 20 minutes away. I don't think this is acute abdomen. That's all I said. 20 minutes away. I don't think this is acute abdomen. It's all the captain needs to hear. And then he just scheduled or he just landed. And I don't obviously know what ended up happening, but when we were all deboarding or deplaning, I saw him walking and he didn't look like he was in pain anymore. So that's a pretty straightforward one. Second one sounds a little more like Jean-Claude's, but essentially I went to the patient. I started asking questions. He was breathing pretty heavily. He said he has COPD. He's on 2 years at home. And he had turned up his thing up to 4. And so I was like, do you guys have Advair? Do you guys have I'm like thinking like total internal medicine. And I was like, I just need to give him a quick bronchodilator. So I literally just gave him albuterol, turned up his oxygen. The captain asked what I think's going on and if they need to land. And I didn't want to answer if I think we need to land. I just said, he's stable right now and could probably be on this increased oxygen for the next hour or so. And then
Where did the albuterol come from? The kid?
The kid. Yeah,
Okay, so
yeah.
I had
the
it.
Did you have to request the EMT?
No. Yeah, good question. So I told the captain, I'm giving this guy Advair. I think he'll be fine for the next hour with increased oxygen, and that's all I did. And I took a seat, got 2 bottles of wine, and then when we landed, I just saw EMT come on and take him in.
So how come EMT didn't cover the first one, I guess? Like, was that the captain?
When I called the captain, I said it was not acute abdomen, should be okay,
Okay,
but it's still the captain's call.
okay.
Yeah. Okay, so this one was, I mean, this could be like a whole hour of a talk. This was like the most intense thing I've ever been through, in medicine. So I show up and he's got blood clots all over his mouth. He's not making any sense. He's sweaty. I'm like, let's get a pulse ox. He was in the 70s, so we needed the oxygen. And I'm thinking, oh no, he's going to aspirate. So of course he did. He threw up again, more bloody. And I'm thinking, is this varicose, GI bleed, cirrhotic? Is this PE because he's on a plane, hemoptysis, because we don't see that too often. Systolic dropped. I tried to put an IV. I couldn't deeply put an IV. And then we tried doing some fluids. It didn't really help. And then eventually you end up kind of being a little more in charge than you'd expect because these German flight attendants were totally calm, cool, and collected. And I'm sitting there going, why are you guys so calm and now these guys up there? And the people next to the passenger was just sitting there. And I'm like, okay, you guys need to get out of these rows. And then we pulled him down into the aisle and we just kind of cleared his airway as best as we could. And I just kept making sure he had a pulse, which he did. It was weak. And then I think all of that was probably the first 4 minutes we get on the phone with the captain. You're like, this is really bad. I think he's dying and we need to do emergency intervention. And he said, okay, we're about, I think it was like an hour to Geneva, or I'd have to turn around. And I just said, that's your call. I told him what the medicine is. And so then I kept doing my thing, and then I got back on the phone and I said, yeah, he's getting worse and we already did fluids. It's not really helping and the oxygen's going to run out. And he said, okay, I'm landing right now in Hansburg. So we landed and EMT came on. I think the patient probably died. They took the patient off and then we deboarded and got stuck in Hamburg.
So they couldn't just take off and then go back to.
No, the flight was there was blood. It was like a bloodbath. There's blood on 3 rows.
So wait, hold on. So you said the kid had epi?
Yeah.
Did you give it to him?
I did not give him that.
But that's like a.
It's a pen.
Muscular.
I'm assuming for like
That'd be
anaphylaxis.
That's
Yeah,
That's
it's a pen for
I know.
anaphylactic.
That's
Yeah, I know.
Yeah.
It could still work.
Or his heart explodes.
But again, at this point, you're just trying to make. But again, at this point, you're just trying to get them to make a decision on if they have to land or not, and get the.
Well,
get
props
people
to
on.
you for
Sounds like-
getting an IV and a.
I didn't get it. She got it.
No, props to her.
It was
Yeah.
like,
Yeah, hypoxia.
and the PhD person couldn't either.
It took an hour, you said?
No, we ended up landing within 15 minutes of it all.
Oh,
It
that's
just
fast.
felt like an
Oh,
hour
okay.
because he just ended up
Yeah.
landing in Hamburg, Germany. It was from Copenhagen to Germany, and we were supposed to go to Geneva. Yeah.
I assume if the person does code that the kit doesn't have like code level epi.
Yeah,
kit.
it doesn't.
Okay.
Yeah, it has that.
Go do CPR for like.
It does have the AD,
Yeah.
but he didn't code.
Yeah.
And he was still mumbling and talking.
God.
The biggest thing for me was the trauma and then not knowing what ended up happening. But ultimately, it was interesting. Well, most of the passengers on the plane, even though I thought they'd be upset, because I think they would have been if it was America, but in Europe they were just like, "Yeah, thanks for your help." And like, everyone got rescheduled within a few hours, and it wasn't that stressful. But the actual incident was stressful. So.
This is
All
yours.
right, now that you guys are woken up, let's talk about more medicine stuff. So that was really just to say, at the end, you just are following your training experience. I think we all would have done the same thing in all 3 cases and would have done the same thing, whatever Anissa did for the stroke patient or you guys on pre-syncope. So we should also be able to do the same thing in the hospital where we're taking care of patients. We become a little bit reliant on our residents giving us information. We become a little bit more reliant on all these articles and guidelines and teasing out what the reality is. And we become a little reliant on the consultants, and it can get us in trouble. So we have to sift through the noise. I found this quote from one of these articles that I pulled up for going through what hospitals have to go through. And it's really just like, how do you put it all together? Guidelines are really population based, specialties like hammer, seize, and nail. Sorry for going quickly, but since we started late, I gotta go through this a little bit faster. And we are the ones that have to own the whole story, whether you're in clinic and getting the patients referred to specialty consult clinics, and you see them again later and their recs don't align with what you're seeing, or us, where it's in real time and you're consulting nephro for hyponatremia and their recs don't make any sense with what you're actually seeing in front of you. So you have to just have disciplined skepticism. They're still specialists who've trained more than us in their respective fields. But at the end of the day, like, they are only seeing what they're seeing, and in that specific, I'm not gonna go through the case, but the hypertrophy case I'm kind of hinting at that I talked to Justin about. I remember going to the nephrologist and just saying, I think we're missing something here because it's getting worse based on your recs. And I looked down and she had a piece of paper of 25 patients. And she's like, which one are we talking about again? And I'm like, and that's my only like sick one out of my 12. And so I'm like, okay, even though I'm mad at them right now, I kind of get it. And then also there's all of this, right? How do you sift through all the noise? So I'm going to use transfusion thresholds as that. I could have done anything. I could have done hypernatremia. There's actually, I don't know if Bryce is on, but there's my passion, which is probiotics, which actually everyone doesn't do, but there's better evidence that says it works, but the guidelines say not to use it. I thought they all would be a little controversial. This one I wanted to be a little less controversial. I think you guys are going to agree with everything I'll be showing here, but you'll still see that some of us on a list of 12, 15 complex cases of ABC or even on co-management when there's other physicians involved, we tend to just kind of get a little, I don't want to say lazy, but like just, paint by numbers. Hemoglobin threshold 7, hemoglobin threshold 8. So this seems easy. 6-9 transfused, 7-1 don't, but like you can't just go that way. So these are the major studies that have come out over the last 20 years, which has really pointed us towards the direction of what type of transfusion role. It's easy. Low hanging fruit question. What was these first two? What did people do before 1999? How was that?
Transfused with 13 or something.
10. It was like 10. Yeah. And then 99 was the first study that they looked at critically ill patients and said that if you transfuse at 7, they actually had better outcomes than if you transfused at 10. They excluded all the cardiac patients. But that was the first groundbreaking study where all of a sudden everyone started practicing different and realizing that blood products can be dangerous. I should say dangerous, have side effect, adverse outcomes, right? Infection, fluid overload. We're treating a number, not a patient. So then orthopedic surgeons were like, we still want to transfuse higher. But they did their own study and realized in hip fractures, it's actually okay. And then the TRISH trial was probably when a lot of us were in training. That was a big one that came out that said in septic shock, 7's also safe. I left out the one that came out in, I think, 2016. That was the GI bleed one. I think it was a Spanish New England Journal study. That was a big one because in most of these cases, they didn't include cirrhotics, GI bleeds, or coronary artery disease. And then that study came out in 2014, and they said actually in cirrhotics you should also aim for 7 and not 8, 9, or 10. But then again, they excluded active bleeders. So I think we always have to be aware of what they're excluding. Then things have shifted a little bit the last 5, 6 years. And I think I didn't get to go this year to any national conferences, but the year prior, they spent a lot of time on the MINT trial, and it actually changed some of what Keck does. But essentially, they started to realize that, well, we never really studied coronary artery disease. And even though I think most internists would say, well, if they're having active cardiac symptoms, we should transfuse higher. But still, people are saying 7 or 8. So they looked at MIs, and then they looked at people with ischemic changes, and it actually, both of them signal that maybe we should transfuse for a higher threshold. And then now the guidelines actually say with vascular disease, coronary artery disease, use your clinical judgment. But I still think people are saying things like transfuse hemoglobin 7 and really only say 8 if they have active ischemia, which is not really the way the guidelines are suggesting it, nor if you're staring at your patient who's becoming symptomatic, that you might be trying to find other differentials. It could always be just anemia. So I put this table together. I think this is a really easy way to kind of refer to things and figure out what the evidence is for when to transfuse. Again, the guidelines say consider less than 8. So I still think the majority of us are not really doing that, but really the data is starting to show that you've got a patient who's here for a UTI or pneumonia. They also happen to have a GI bleed and you're transfusing for 7, and it's somewhere deep in the problem list under chronic problems that they happen to have like 5 or 6 years ago a stent. And I know the way I'm presenting it might make it sound like, well, no, you would think about that right away, but no, when we're on medicine, sometimes we're not thinking about it right away. Those are the ones you might want to think about transfusing earlier rather than when it drops below 7. So this has been studied, and when we're talking to our residents, just especially since they're not starting, and it's becoming a little bit more difficult with the residents to kind of sift through all the guidelines, really just talk about how, yes, 7 is what we should be doing, but these are the exceptions, and please keep practicing what the exceptions are and remind us. Doesn't mean you always have to get transfused for 8 when they have vascular disease. You definitely should if they have active ischemia or symptoms. But vascular disease, you just have to think about, how relevant is that vascular disease. We had a patient on B a couple months ago who was transferred here, maybe it's 6 months ago, transferred here for an eye issue, but then we found they had poor Dopplers and they ended up getting surgery with vascular surgery. And we were just transfusing for 7 and we weren't really even thinking much of it, to be honest. And no one really prompted us to transfuse above 8. And then a couple of days later, we were all debriefing and thinking about it, and we probably should have used a higher threshold. And really, that's what what JAMA and AHA are saying about what to do. So, there's an article that just came out, I say last year, in this journal of thoracic disease, and the leading authors are all experts in their field, and they are literally pushing for more studies to look at this because they're finding in their Medicare review of adverse outcomes, patients being transfused for 7 and no one really looking at 8 or 9. And they're basing off of what they saw in the MINT trial, sub-analysis, and their own clinical experience. And really it comes down to this. I think we all agree, if they're having symptoms and frailty, that's different from when you're transfusing, but maybe we're not all on the same page on volume tolerance and bleeding trajectory. So really think about your patient in front of you and consider not necessarily following the guideline and actually just looking at the patient in front of you. Okay, so I'm going to shift a little bit, building off of that. Yeah.
And I don't know the journals that well, but
yeah,
we had this number of 7 in that trial. Did they look at below 7 and saw that there was negative outcomes from below 7?
No, they didn't make thresholds of
Because I
7.
think that was mentioned at the conference this year.
Yeah.
That going forward, I think there's an upcoming study that they're looking at some
A lower threshold.
and whether there is with low morbidities, but for the common patient. I mean, we arbitrarily chose 7, I think, in that trial, but then
yeah. So it was 8, 9, or 10, then it was 7 or 10, then it was 7, 8, or 9. They've never really gone below 7.
Yeah.
I'd be skeptical. I think part of the problem with our field is we're always thinking more is worse because we're internists and we want to get people out of the hospital, and we're like, why are we even trying to, if someone's been living in the 7s for, I don't know, a year because of chronic disease, and suddenly it drops to 6, is it that big of a deal compared to someone who's been in the 12s that drops to 7? So I think I get probably why they were studying that, but I'd be very nervous if they end up showing some good outcomes and suddenly now people are changing their behavior to be even more restrictive. Because
what gain would you get from lowering the threshold that much? It just seems
I think there's other elements at play here, right? There's Medicare that really actually penalizes hospitals for transfusing and using a lot of blood products. There's hospitals that really restrict. I mean, this Owen hospital will really get on you if you're transfusing too much. And so I just think sometimes you got to look at who's studying this and what their funding is coming from. But I will just say, Uni said, if that's what they said, that's fine. But the last 3 years, it's actually going in the other direction. That maybe we're going too low of a threshold. So it'll be interesting to see what they say with that new one you're talking about. I mean, there's other things, right, Justin? It costs money. These blood products cost a lot of money, and not a lot of the community hospitals have.
I mean, that's why I think the 7 threshold is so popular.
Yeah,
right? I mean, there's obviously benefit, but
so okay. So here's a patient. We're gonna, now that we have 7, you 4 and you 3. So you are coming in on switch day, and your sign out is basically that 64-year-old came in with IBD. They have blood per rectum. The hemoglobin is 6.4. GI is consulted. Transfused 1 med unit. Hit medicine. When the resident's presenting the case, they tell you that so problem 1, GI bleed, secondary IBD. probably IBD flare, we're gonna get all the stuff, right? CRP, ESR, pectin, we're gonna get a GI consult, we're gonna transfuse above 7. So, how do you approach this patient? Pretty straightforward, don't worry, but we'll ask more questions. Go, talk. We got 15 minutes left.
Wait for Jay.
Confused the show.
Vitals.
Just kidding.
It's a good, yeah.
Go up the patient.
Press sour.
Like,
I guess
Get a
localizing
bag.
strictly to saying it's IBD.
And the rest was like, oh, the people are fine. I'm like, yeah, we're like a week that's why.
So my question is, how often do you check the CDC? Because I
Hemodynamically and
I think, even from sus, there's so much variability.
Yeah, I mean, are you,
Like, you know, do they?
well, are you like
If that
angry
they
strictly to an IBD
an hour
flare, or could this be an
But when
emergent
is
like
it?
GI first hypergenic bleed?
Most I'll do,
I think
the most I'll do is Q6, because otherwise.
They're just making it more.
Yeah. Q6 is like the maximum, yeah.
So I'm hearing a lot of things. I'm already hearing a little bit of a conservative approach, transfuse, and then you don't need to get CDC. So actually there are guidelines and evidence. So I heard you say Q6. So if they're symptomatic tachycardia, evidence of still bleeding, it's Q8. If they're hypotensive tachycardic, evidence of bleeding, it's Q6. Q12 really, if they don't have any more symptoms, but they came in with symptoms, and you really only have like one vital derangement, that's Q12. And then the daily is like the one that comes in ETC who says they had melena, but you don't see it. They drop. You give them a blood. All their vitals look good. You call GI. They're gonna scope the next day. Those are like your Q day ones. So because of time, I want to go through this a little bit quicker. But all of you guys said the appropriate things: consult GI, see what's happening. But you find out that the resident didn't give you more of the history that you needed to know, and you find out that they actually went to the ED because they were in the opto clinic. And they were having right eye vision changes, and they were diagnosed with ischemic optic neuropathy. And when they were in clinic, they're like, I can't see. So opto says, I think you have ischemic optic neuropathy, and what anything happened recently? And she says, oh, I had blood in my stool. And then they know she's lightheaded, so they send the ED for pre-60. Now, when they get to the ED, all that stuff's not in the note. No one talks about it. They just focus on the IBD stuff. So because of time, what would you do anything else differently?
Transfuse higher.
Treasury's higher to what?
8.
8. But you're just saying that because I said that?
No,
That's what you would do?
Mhm.
I don't know if everyone would do 8, but okay, we'll keep going. What about any other consults? Yeah, you call it though. Okay, so here's the problem. So on Friday, patient came in, basically what I just described. They transfused, they called GI, they called opto, everything happened on Saturday. You guys know what happened. Did GI scope?
No.
Nope. So what'd they say?
Keep on transfusing.
Transfuse and we'll maybe do procedure Monday, right?
Yeah.
What opto say?
They
Didn't say anything
that.
because
They didn't
it's
say
the
that.
weekend.
No, opto came in, opto came in.
Oh.
Oh, they came in.
Yeah, they checked vision, they said it's the same as it was the day before,
Yeah.
so they said transfuse.
Transfuse.
Love it. Okay.
Care per primary.
So on Saturday night, so Saturday I get the case and we call GI, we call opto. We tell them everything we need to tell them. Honestly, a list of 18 I had that day was like my least active patient because how many IBD GI bleed flares you have, right? And the right vision, she's talking to me, it didn't look that bad, but obviously she described it. So really we talked about transfuse. We did say transfuse above 8 because opto was pretty big about optic neuropathy, which I ended up having to then look up because that was a new thing to me at the time. And we never let the maps drop low, and the hemoglobin went from like 8.2 to like 6.8 overnight on Saturday. They got transfused, bring it up to 8. And then Sunday, I see the patient, similar story, just a little blood, but all the studies are coming back negative now for an IBD flare. I call back GI. The fellow who left the note on Saturday said, why are you calling me? And essentially said something along the lines of like, we already told you we'll scope on Monday. And I said, but I don't think this is IBD anymore because there's no white count. None of these markers are coming back. She's still having bleeding. Well, did you do a digital rectum? So, okay, so resident does it. There's a little bit of blood in the vault. And so we tell him that, and he's like, just transfuse symptomatically. And opto, we couldn't get a hold of on Sunday. So Monday morning, we walk in and she's blind. She's fully blind, irreversible vision loss. So it turns into a really good M&M, really good journal club, really sad moment in my life. and turns into a really long case from 2016 to just last year. I got served on my kid's second birthday, I think. I was setting up the birthday party, and this case happened March 2016, and it was January 2019. So it was his first birthday, and I'm setting up the birthday party, and then this guy goes, "Are you Rishi?" And I go, "Yeah, you the taco guy?" And he goes, "No, you've been served." And so I get these papers.
Like, this is coast to coast, right?
Coast to
How many
coast,
lawyers
yeah,
in here
yeah.
is coast?
So the key on this case, and in terms of just overall care, and going back to sifting through the noise and following guidelines, and the whole point of the talk is really trusting your clinical judgment and documenting really bad, really importantly, and not just kind of following things, paint by numbers. So the chart doesn't have to show that you're right. It just has to show what you were thinking and what the lawyers are going to look at, especially now in California. So we've already in our group, just under confidentiality, from 21 to 24, we had 0 in our division, and from 24 to now, we've already had like 5 cases that the malpractice group has had to look at and get statements, and none of them have gone to trial, but all of them required a lot of different things, one of them a deposition. So we're going to see more of this. It's another talk altogether. California had some of the best tort reform for the longest time, which tort reform means limits to the amount you can sue. New York has no tort reform. You can sue for as much as you want. So I'll tell you guys in a second what happened with this case. But in California, it used to be like 125 to 250K, which doesn't make a lot of lawyers want to get up and really take on a case. But that is now extended. The statute of limitations is extended. So we're going to see a lot more lawsuits in California than we did in the past. So being careful about copy forwarding notes, especially when we have resident notes being written, like, on a busy weekend or busy weekday, like it's hard to correct their errors, but trying to, at least on your ones that are more sick. Making sure there's clear rationale and contingencies really helps you. So here's what happened in the case. So the deposition was mainly about, did I call the GI attending? So I didn't. Did I call the opto attending? I did not. And then one of the notes did say, so the Saturday note said transfuse for hemoglobin 7, even though we never let it go below 7. And even though I specifically remember on round saying above 8, even though opto and GI's notes said above 8, I signed that note and it said below 7. So they really pushed on that. So after the deposition, so they sued the hospital, the nurses, the hospitalists, the opto attending, and the ED, because they said that all of this would have been resolved, which honestly is not that incorrect if they would have been more complete on the history, because that was nowhere in any chart. The opto stuff was not on the chart at all. But they didn't sue GI, so they didn't sue GI because lawyers don't have to. It's different when you're in legal cases. They can pick and choose who they want to kind of go after. So the objective review of the case is the maps never dropped below 65. So they got an expert witness from critical care, hospital medicine, and GI on my side to say all this stuff. Maps never dropped below 65. Dr. Mehta got the case on Saturday morning. He called GI, he called opto, he transfused, he did a workup for if this is IBD. He followed GI and opto notes. Maps never dropped below 65. The vision was checked every day. Sunday, there was a note that said that we don't think it's IBD, we think it's hemorrhoids. And opto did actually write a note saying that the vision loss likely started prior to all this, and maybe there would have been nothing to do to prevent it. But ultimately, the case didn't settle. It went to court. I had to go to court I don't remember when it was now. December, January, third week of January. This 6 months ago. And it's tough. You're sitting with a jury of your peers. What are your peers? First of all, this is Long Island. I'm in Jamaica, Queens. You think any of them are doctors, nurses, lawyers, engineers? No. They're all like 20 to 30-year-old who are seeing the patient blind and the husband upset, the patient very upset, and the lawyer constantly saying, why didn't Dr. Mehta call the GI attendant? Why didn't Dr. Mehta call the opto attendant? Why is he letting the residents sign these things? And so ultimately found liable for tort reform. So the jury ultimate decision said that the clinical team followed guidelines, not the patient. They did not escalate, and the documentation did not show the urgency. And so it ended up costing $6 million. She won $6 million. 1.5 for me, and then from ED, I think it was like 4.5. And they're going after the ED doctor's personal assets right now.
What?
But I settled. Yeah, so I'm good, but he's not. And so the point is
So going against his what, I'm
Well, hold
sorry?
on.
personal assets.
Quick question.
Yeah.
This is all covered by your malpractice, right?
No, so malpractice covers a certain amount of money.
Yeah.
And if the lawyers want to go beyond that amount because they have case law to protect them in terms of like precedent. So the thing is, the jury gets told how much money usually gets paid out for a stroke or a MI or vision loss, and it has to be based on precedent. So in New York, there were just a lot of cases that got a lot of money for these things, and probably for good reason because there are bad doctors out there, right? And so they have to, by obligation, they have to follow what has been done in the past.
Yeah.
And so by obligation, they have to reward this amount of money.
Right.
And the malpractice, most malpractices only cover up to like 3 mil. Ours at Keck covers 2 mil.
Really?
And
So
it's
then-
different in California because there's tort reform. and
So anything over, they can go after you.
they
first?
could, yeah. Yeah, okay. But
Okay.
when you get to that point, it's a whole other thing. Like you have other lawyers that can get involved, your personal lawyers.
That's the kind of thing only happened in New Mexico or something like that.
No, it happens everywhere. It doesn't happen a lot to us because we are not surgeons, but in surgery world, like you get involved in these cases all the time. But again, bringing it back to the talk, the flight and the legal case was to get you guys not to fall asleep. But the point of the talk is back to following your gut and documenting things. So older patient with active bleeding, restricted transfusions typical, but using a higher threshold. I could use any of this stuff here. And it probably would have got me out of it. I didn't. And then there's really good articles on this. So National Academics, this journal, Improving Diagnosis in Healthcare, they talked about how most malpractice claims come from essentially not documenting well and not following through and pushing consultants when they end up getting to be kind of clear for everything if they so choose. And so there's this idea that defensive medicine is bad. And it's not, the mindset needs to change. It's not that you're being defensive. You're not ordering, I didn't go out there and like transfuse for 10. That would have been defensive, right? I didn't go out there and get all these unnecessary imaging and tests. That would have been defensive. But I wasn't defensible. I didn't document well what we were doing and why GI was pushing to Monday. Which I think actually they made the right call to push to Monday because it wasn't like she was actively bleeding so much. It was just a couple episodes a day. And her vision wasn't changing and we didn't think it was IBD. So I don't actually fault GI for waiting till Monday. We're all used to that kind of a thing. They usually will only swoop if they're like really, really unstable. But your note is the most important thing. And I'm bringing it up because I myself don't always write the greatest note. I'm sure all of you guys sometimes get through your notes. And now we have residents who are writing notes and we're signing their notes. And you have to look through the note. That's the point of that. Yeah, what was that?
Those notes suck.
Yeah. All right, any questions about guideline literalism, documentation risk? I don't think we have anything about the flight anymore. Yeah.
But if you write an addendum, but it doesn't match with what the resident wrote,
That's
what are
okay.
they gonna?
That's okay.
Because like sometimes I always might write my own addendum, but I'm like, I can't be bothered to fix every little thing.
Yes,
So I just
exactly.
write my own thing.
Yeah. So that would have got me probably out of this. Because the second day, all I had to do in my addendum was thresholds 8. Probably
And they would ignore what the
it
resident.
supersedes it legally. But I, on my second note, just wrote agree with resident.
So literally it was just the threshold of 7 and you're saying that if you had just written the document threshold of 8, then.
I'm not saying anything. I didn't think I did anything wrong. I'm saying what the jury did.
I know,
Yeah,
but
yeah,
I'm
yeah.
just saying, if they had saw that you documented threshold of 8, then the lawyer.
I
would've-
think in the
Must have gone off.
deposition and decision on whether to settle or not, if they couldn't get the team, I won't just say me, the team, they couldn't get if they had proof that the EDs tried in the beginning to protect the vision, which they didn't, they were really just talking about IBD. If they had proof that I was saying over the weekend, this is huge, her vision's being lost and she got an active GI bleed, then they probably wouldn't just settle that of court. But the lawyer saw, oh, the ED didn't really do a good job of signing out, and the hospice over the weekend with residents, they're actually going way after the hospital. It's not really,
Yeah.
it's mostly the hospital. But good question. Okay, so we're at time, but I have like 15 slides left. So I'm gonna try to just give you some big items on this. because part of the rest of the talk is really anchoring and specialty bias. So I just think it's beyond what we've already just kind of talked about and think about. And I know we used to, those of us who've been here in the group long enough, we used to have a chat called diagnostic error that Mike Kwok started. Like, it's not just a small thing. It's really what is considered the next phase of medicine that in order to help patient safety, because whenever we look at bad cases, it's usually anchoring at the beginning or specialty bias towards the end. And like these articles came out just 2 years ago and talked about how we have to be collaborative as a group. And recognize our biases and why things might not be going the way they should be going. And so ideas are, this is stuff for really residents, right? We all know this. We don't have time to necessarily write this out, but we can teach the resident. Like, hey, stop writing hashtag elevated Billy, hashtag elevated LFTs. That is the biggest pet peeve of mine. Just write obstructive jaundice likely due to choledocholithiasis versus whatever else you think it is, and push them to write it rather than having to make you guys feel like you have to write that whole thing. But any sort of reasoning really also then helps the debiasing. So overnight, when someone looks at the case or a consultant looks at the case, these are some ideas that you can do. Especially bias. I mean, how many times have I called cardiology and they told me there's no eval need? And I got a patient where the echo shows segmental wall motion abnormalities. Of course, they're going to say that's not a functional exam, it's not a stress test. We all know that. But then the tropes are going up, but they have an infection, so they're saying it's all due to demand ischemia. You're still uncomfortable. I'm telling you guys don't like to stay. Needs to discharge the patient 3 days ago. And I'm just teasing her, just teasing. And Hillel, if he was here, would keep the patient for a month and do x-rays of the shoulder, right? Like, we all practice a little differently, but ultimately, like, get in the room with the attending and try to just push back. And how do you do that? Like, it's very tough because they're also busy too, right? So they're gonna have different priorities. They're not gonna be the same as us. I'm not gonna get into incentives, that's a whole other topic. But essentially, you know, how do you frame it to them? Like, it's just about framing. So you see all this stuff. This case I had also, where they actually said discharge and we'll see in 2 weeks, and then I pushed and pushed, but then like 2 days later, they actually finally did a cath. I got Sean Gogier to do the cath, and they found widespread obstructive artery disease, and they gave him stent and RCA. But anyways, so you see these things, they're seeing it. They have a student, maybe a resident, writing a note on 20 consults. They're presenting to a fellow, and then when the attending comes to round, they usually have the fellow kind of giving a one-liner right before the resident even presents the whole thing. The attending already is thinking whether they're going to cath or not, and they might miss all this stuff. Like, they'll just say, oh, the trope's due to this, the echoes do this. You can talk to them and say, okay, can you just explain to me why it's still going up when we're treating pneumonia? I understand that you say that this is an anatomic thing and not a functional thing, but like, why is the segmental wall nationality happening so specifically on the inferior wall, which corresponds with the RCA, right? Document why you're concerned. If something happens, you don't end up saying you didn't get to push back. And then this is what I did actually just last week with the hypertrophy case I was telling Justin. I just literally, you kind of have to be humble and just be like, look, I might be missing something, but the sodium went from 121 to 118 based on your recs. Am I missing something? And you just try to push back up as much as you can. This is also why I always say, please SRM the specialists who are being unprofessional. And the reason why we have the professionalism program at Keck, the reason why we have the cup of coffee isn't because we're just trying to get rid of a-holes at Keck, which we should, but it's because all the studies say that if you don't have a safe environment to discuss things, if you feel like they're going to pick on you, or you feel like it's just not going to be a constructive conversation, then you don't end up asking and you don't end up pushing. And so we have to be collaborative with our specialists. And I think we did for a while with cards and pump crit and ID and nephrology. I think we still do with nephro because we take a lot of the patients. I think we still do with cards and pump crit, but when new attendings come on pump crit, sometimes it's like we're back to square one where we have to re-explain where we're coming from. It's part of why I always feel like if you just break bread with someone, like, and understand where they're coming from, things can get better. Okay, so we're 5 minutes over. So it seems simple, right? Just follow your training, document your reasoning, be patient focused, work with the whole team. Same thing applies to the first case of the flight, right? Like, you're following your gut, you're documenting, You're trying to focus on the patient, you work with the team, work with the captain of the plane, but it's actually not that simple, obviously. So just, I think ultimately really follow your instinct, make sure if it doesn't feel right, the story and the physiology, especially the trajectory, start looking at exceptions from the guidelines, start looking at exceptions from the specialists. And if you go back all the way to the flight, like look at exceptions of why you need to land the plane. And I found this in the Annals of Internal Medicine, where they said a 30-second checklist is a good way to do it when we're all signing out to each other. Especially if you're like, you're signing out like 8 or 9 primary patients and you're telling them 2 can go, 3 are complex, 2 are rocks, and like 1 that's like kind of don't know what's really going on and you've been trying, just say like, hey, I don't know if what we're doing is following all the facts. Obviously, we're still trying to be succinct in the sign out. This is what Nephro said, this is what Card said, but they didn't answer this. And I don't know if it's following the guidelines because of XYZ, maybe you should think about doing this. So I think, obviously this is a clinical conference, not a faculty meeting, but I think we should start thinking as we work on this year, how to make our sign outs better. I think separate from this talk as a group, there's a lot of work we could do on our sign outs, because I think some of them are so long that you lose what you need to do. It's not standardized, we all have different ways of doing it. But if we can standardize it, make it more succinct, maybe be able to walk away without having to do an email on a Friday night or Monday morning or Sunday night or Saturday morning, depending who you are. Then focusing on things like story is a good way to sign out the complex cases. And that's it. That's the talk. 8 minutes overall. You guys got to answer a question. It goes back to the first one. So what type of bias you need to be aware of when taking care of patients with multiple problems, and which laws protect physicians? So anchoring bias, aviation, medical assistance act, especially bias, good say, Hawthorne effect, cognitive bias, mistake, E, A, and B.
E, A, and B, E, so E.
Yes, put E. So put E. Any questions?
Wait, what's this?
E.
Sorry, we went over, guys. Any questions from anyone online or no?
Josh Sappin is asking.
Oh, I don't know what the CPT.
What is the CPT?
I don't know what the
for
CPT
in-flight
code is.
Patient is.
I'm sure there is one. I don't know.
What-
But
how
if
are
you bill
you-
it,
how are you
then
billing
you bill
this?
it, then you're not doing good.
You're not, yeah.
Happens to know, like if they go here, they take your personal
Yeah.
assets, like, is it like paid over a period of time? I'm guessing, like if it's like 1.5 million, I don't have 1.5 million.
Yeah, it's overtime. Yeah. That's why you should all get umbrella insurance to
Mhm.
protect assets.
I have 2 questions.
Okay.
So one, I tried to get umbrella insurance and they explicitly told me that it doesn't cover this. So I
doesn't-
was curious
it
as to
doesn't-
how you got that.
So I have umbrella insurance. It doesn't cover when you're right. Thanks for correcting me. It doesn't cover when you're in a medical malpractice and they go after your assets, but it does cover if they want to go beyond into a civil case.
Okay. Oh, and 2, I was wondering if you had, I know it varies state by state, but if there is any data on like what percentage of malpractice cases actually end up with the physician giving up personal assets?
Oh yeah, it's very, very,
That's
very
what I
low.
understand.
Very low. First of all, the majority of cases don't even go to deposition. They
Mhm.
get dismissed upon the original lawsuit being claimed. And then so that's probably 70%. And then the other 30, there's an investigation and a deposition, and probably out of those, the majority of them, 90% are settled out of court. And then
I see.
and then after that, they go to court. So for everybody in this group, and so every USC physician, we're all under beta malpractice. It's called beta health malpractice. Coverage up to 2 mil. And whenever there's a claim by a patient about their care, the risk management department finds out about it, and they first call you, reach out to you, get your side, look at the case, and then they advise our lawyers whether this go forward or not. And then once that happens, Beta Healthcare gets involved, and then they take care of all the rest. Even in my case, I didn't really, other than the emotional stress, I didn't really have to do anything. I found out about it at my kid's birthday, and then after that, a lawyer, the insurance handler called me to get some insight, and then he found out this is actually they're gonna take this case forward because you have a bad outcome. And then they provided the lawyers and all of that. And then at some point, I think like 3 years in, I got some letter that said, you may wanna consider a personal lawyer on top of it because your malpractice only covers 2 mil and they might go after your assets. And then I had to do that, but that was also, they walked me through the whole thing.
Okay.
Was what happened, is that applicable in this state? Because you're saying that there's a cap.
Yeah, there's a cap. They can stack it, but there's a cap. I can send out I think I talked about it one of the
I've never heard
meetings.
of anybody getting personal umbrella to cover like
No.
malpractice cases that go over.
Yeah, that's what Mungla just asked. You can't.
uh,
I meant if later on they want to go after you in a
I
civil.
guess usually for like personal
Yeah.
injury stuff, right?
Yeah,
Like stuff that
yeah.
happened outside of work.
Yeah, in a car accident. and
Yeah,
They
that
want to
kind
go
of
for
thing.
personal
Yeah,
stuff.
sure.
Yeah.
Oof,
Yeah.
that's rough.
All right. Any other questions? Great. Thanks, guys.
Thank you guys.
Thank you, Dr. Mehta.
Yeah.
Thank you.